This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Ilara. Today we're looking at a fascinating new study from the March 2026 issue of Acta Neurochirurgica, titled A Simple and Aesthetically Pleasing Floating Craniotomy, How I Do It. It comes to us from the Department of Neurosurgery at Daeping Hospital, Army Medical University in Chongqing, China.
This is a timely topic, Ilara. We've all been through the decompressive craniectomy cycle. You do the life-saving hemicraniectomy, you store the bone flap, either in the abdominal wall or a freezer, and then months later, you go back in for the cranioplasty. But that second surgery isn't benign. We see infections, bone resorption, and syndrome of the trapheed.
Exactly, Dr. Aris. The authors, Tianjun Li and his colleagues, highlight that while standard decompressive craniectomy, DC, is effective for intracranial pressure, ICP, control, the morbidity associated with the subsequent cranioplasty is significant. They are proposing a floating craniotomy technique that essentially bridges the gap between a standard closure and a full craniectomy.
It's an evolution of the hinged or floating techniques we've seen before, but with a very specific mechanical twist. Before we get into the how-to, let's refresh the residents listening on the why. They mentioned the Monroe-Kelly doctrine in the paper.
Right. The doctrine reminds us that the skull is a rigid vault. If the volume of blood, CSF, or brain tissue increases, something has to give or the pressure skyrockets. By creating a floating bone flap, you're effectively expanding that vault volume, creating a buffer zone for mild to moderate swelling, while still keeping the brain protected.
And maintaining the cosmesis. There's nothing more heartbreaking for a patient than that sunken skin flap look while waiting for a cranioplasty. So, Ilara, let's walk through the technique. It starts with the craniotomy itself.
The authors emphasize a standard large craniotomy, at least 12 by 15 centimeters. This isn't the time for a keyhole approach. You need real decompression. They also insist on removing the temporal squama and the lesser sphenoid wing down to the floor of the middle cranial fossa. That's a critical step for basal decompression.
Agreed. If you don't take the bone down to the floor, you're not truly decompressing the temporal lobe. Now, once the dura is opened, they suggest a stellate or curvilinear fashion, and the intradural work is done. How do they decide who gets the float versus a standard off-with-the-bone craniectomy?
That's a key clinical decision point. They suggest this for patients where the brain swelling is mild. Specifically, it shouldn't exceed the cranial surface once the flap is replaced. They actually measure the ICP intraoperatively. If it remains under 10 millimeters mercury after replacing the bone flap and attempting to approximate the scalp, they proceed with the floating technique.
Okay, so the brain isn't mushrooming out. It's tight but manageable. Now let's talk about the fixation, because this is where the paper gets really innovative. They use a specific suture and knot configuration.
This is the most interesting part. They use a 1 millimeter high-speed burr to create 3 sets of drill holes symmetrically, one in the frontal region, one parietal, and one occipital.
And they don't use titanium plates to fix the whole thing, right?
Not initially. For the frontal hole, they pass a non-absorbable 0-0 Prolene suture and tie it with a standard surgeon's knot, but they leave a large loop. This allows the flap to move upward but keeps it from sliding out of place. But the real magic is in the parietal and occipital holes.
They use slip knots there.
Exactly. They tie slip knots with at least 2 centimeters of slack. This slack allows the bone flap to float outward as the brain swells post-operatively. But here is the clever part. They don't bury the sutures. They exteriorize the ends of those slipknot sutures through the scalp.
It's almost like a temporary external fixation for the skull. And I notice they do use one titanium plate.
Yes, they secure one end of a titanium plate to the bone flap at either the parietal or occipital region. This acts as a stopper to prevent delayed flap subsidence, so the bone doesn't sink below the level of the skull once the swelling goes down.
That's a common complication with floating flaps, the sinking bone flap. That plate is a simple insurance policy. Now, let's talk about the scalp. The paper mentions the surgical anatomy of the layers. Why is that relevant here?
They emphasize the loose areolar tissue layer between the galla and the pericranium. They perform a blunt subgallo dissection around the incision. By mobilizing the scalp in this plane, they increase scalp compliance. It gives the scalp more stretch so the bone flap actually has room to move outward into that space.
So the surgery is over. The flap is floating on these 2 centimeter Prolene loops, and the suture ends are sticking out of the scalp. What happens in the ICU?
Post-operatively, it's about monitoring. They do dressing changes every 2 to 3 days. In the paper, they show a case where on post-operative day 3, the CT showed significant edema, and the bone flap was clearly elevated. It was doing its job. By day 9, the edema had resolved.
And that's when the adjustment happens. This is the part our residents should pay attention to as it's done at the bedside.
Right. Once imaging shows the edema is gone, they use an elastic compression bandage to gently push the bone flap back into its anatomical position. Then they take those exteriorized slipknot sutures. You stabilize one limb of the suture with a hemostat and tension the other limb with a second hemostat. You're essentially tightening the knot from outside the skin to lock the bone flap down against the cranium.
It's almost like a temporary external fixation for the skull. And I noticed they do use one titanium plate. It's almost like a temporary external fixation for the skull. And I noticed they do use one titanium plate. It's almost like a temporary external fixation for the skull. And I noticed they do use one titanium plate. It's almost the aesthetically pleasing part they mention in the title. You get an anatomical reduction.
The follow-up imaging at 3 months in their study showed perfect anatomical reduction with no subsidence, and the clinical photos at 3 weeks look excellent, no deformation at all.
It's an elegant solution, but we have to talk about patient selection. This isn't for everyone. The authors are very clear about the limitations.
Definitely. They explicitly state that this technique offers limited decompressive volume compared to a standard DC. If you have a patient with fulminant or malignant cerebral edema, like a massive middle cerebral artery stroke or a high-energy traumatic brain injury with immediate herniation, this floating flap won't provide enough space. You have to go with a standard craniectomy in those malignant cases.
It's that middle ground patient, the one where you're on the fence. Should I leave the bone off just in case, or can I put it back? This gives you a safety net. What about complications? They have a specific list of avoidance strategies.
First is strict patient selection. Don't try this on a mushrooming brain. Second, they warn to position the drill holes away from major vessels to avoid hemorrhage. Third, meticulous hemostasis is a must as you're creating a potential space. They also recommend protective postoperative positioning. Don't let the patient lie on the operative side and push that floating flap back in prematurely.
And they still advocate for ICP monitoring. Just because the flap can float doesn't mean you can stop being a neurosurgeon. You need that data to guide your management.
They also mention standardized antibiotics and strict aseptic technique, especially since you have sutures traversing from the bone space through the skin.
That would be my biggest concern, the risk of infection with an exteriorized suture. But if the sutures are removed or trimmed once the flap is tightened and the wound is handled well, the risk seems manageable compared to the risk of a secondary cranioplasty.
Exactly. The paper notes that after tightening the slip knots, the patient continues to wear the elastic bandage for 2 to 3 weeks to ensure the flap is fully secured while the healing process begins.
Let's summarize the technical pearls for the listeners.
Sure. 1. Large flap, at least 12 by 15 centimeters. 2. Full temporal decompression to the middle cranial fossa floor. 3. 3 suture points, frontal, large surgeon's knot loop, parietal, and occipital adjustable slip knots with 2 centimeters slack. 4. Exteriorize the slip knot ends. 5. Use 1 titanium plate as a subsidence stopper. 6. Blunt subgallo dissection to give the scalp room to move. 7. Push and tighten post-op edema resolves on CT.
It's a very logical progression of the hinged craniectomy concept. By making it floating rather than hinged, you theoretically get more uniform volume expansion. And by making it adjustable, you solve the problem of the flap never quite sit right afterward.
It really addresses the Monroe-Kelly doctrine in a dynamic way rather than a static one. Instead of a yes or no to bone replacement, it's a yes but with room to breathe.
Well, this has been a great deep dive into a very practical technical note. For the residents, I'd suggest looking at the figures in the paper, specifically Figure 1, which shows the knot configurations. It's a simple technique, but the execution of those knots is everything.
Agreed. It's a great addition to the neurosurgeon's toolkit for trauma and moderate edema cases.
That's all for today's episode of the Neurosurgery Hub podcast. Thank you, Dr. Ilara.
Thank you, Dr. Aris.
We'll see you all next time. Stay sharp.